Hi, my name is Danielle Weglars. I'm a nurse with the lung transplant department at Michigan Medicine. Together with my colleague, Misha Mercurio, another nurse in our lung transplant department, we are going to present to you our lung transplant education course. This is the course that all of our lung transplant evaluation patients go through at the beginning of their lung transplant journey. It is fairly comprehensive in that it includes both the evaluation for lung transplant, what it's like to be on the wait list, and also life after lung transplant. So let's go ahead and get started. If you're looking for additional information besides this class, you're welcome to visit our lung transplant website. So just Google Michigan Medicine Lung Transplant, and it'll take you to our website. We have education videos in addition to this class, and also an education binder in a PDF form. So we have a binder that we give to all of our evaluation patients. It's that exact thing, just in a PDF document so that you can reference and disperse it to family and friends if needed. Two other good resources are going to be the Organ Procurement and Transplantation Network and UNOS, the United Network for Organ Sharing. The OPTN is the government agency that monitors and regulates organ transplant within the United States. They then contract out with UNOS, who manages the national transplant waitlist. They manage the waitlist for all organ types. So whether you're listed for a lung transplant, heart or kidney or liver, all transplant recipients are listed through UNOS. Both of these organizations have excellent websites with a lot of good information. So rather than looking all over the place and potentially getting some bad information, I would suggest heading to these websites. So let's take it back to the basics. Lungs are a pair of air-filled organs within the chest cavity. They allow inhaled oxygen to be absorbed into the bloodstream and circulated throughout the body. And they also allow carbon dioxide, which is not used by the body, to be removed through exhalation. You are here reviewing this video because you've been referred to U of M for a lung transplant evaluation. And generally this is because your pulmonologist believes that lung transplantation is now the only available treatment option. You've exhausted all other treatments for your lung disease. And so only at that point can someone be considered for a transplant. But what is transplant? Lung transplant is the surgical replacement of either one or two badly diseased lungs with healthy lungs from a human organ donor. It's important to recognize through this presentation that every aspect of your life will be impacted by lung transplant. There's a lot to take in. There's a lot of responsibilities both before and after transplant, a lot of follow-up care and medications and potential complications. And it can feel a little overwhelming. The question you have to keep in mind for yourself is, will this improve my quality of life? Because that's our main goal. Our main goal is to improve the quality of life for patients with end-stage lung disease through transplant. Sometimes patients will participate in this class and they'll realize that this is not going to improve their quality of life. It's not the right next step for them. And that's okay. It's a personal decision. But for many patients, this is going to be an opportunity at increased quality of life for them. And that's why we do it. There are many different indications for lung transplant, most commonly emphysema, pulmonary fibrosis, cystic fibrosis, primary pulmonary hypertension, but there are many others. If you don't see your disease on this list, don't worry, not totally comprehensive. Each different disease has their own set of requirements to meet before someone can be considered for transplant. They take lung function tests and oxygen requirements and things like that to determine whether or not it's time to refer for transplant. Generally, if you're watching this, you're at that point already.
So now we're going to go through the journey of your lung transplant. At this point, you've been referred to Michigan Medicine for an evaluation, and we're going to start through your medical evaluation portion of that. So lung transplant evaluation includes a pulmonologist evaluation, your education class, which is this, a social work evaluation, nutrition evaluation, meeting with the financial coordinator, and also keeping in contact with the pre-lung transplant coordinator, along with a bunch of testing, and then in the end, a surgical evaluation. So you're going to start with, or you may have already met with, one of our lung transplant pulmonologists. They will do the medical evaluation side of things. They assess the extent of your lung disease and if you are suitable for transplant or not. They also manage any of your transplant-related medical needs prior to transplant, as well as your follow-up care after transplant. The next group that you're going to want to be in close contact with is the pre-lung transplant coordinators. They are really the ones that will help you stay on track to complete your evaluation. They are going to be your go-to person for any questions or concerns that come up during your evaluation process. And even when you are actually listed for transplant, they're going to help you schedule any of your testing that's needed, get all of your imaging studies. They're going to help get all of your records located if we need to request those from other facilities and things like that. So good communication with that team is really essential to your transplant care. After you meet with a pulmonologist and with the coordinators, you are going to be set up for a meeting with the social work team as well. They meet with you and your caregiver support people to really go through an extensive evaluation. They want to make sure that not only you, but also your caregivers have good coping skills. They want to help you through any type of substance abuse history or mental health history. They want to make sure that you have a strong support system. Support is really essential, again, to your lung transplant journey. We do require you to have 24/7 care support for about the first 2 weeks after you go home after transplant, but you may need 24/7 care support for even longer than that. So really they help you work through getting that team set up, making sure that you have enough people around you to help you through this extensive process. But they're also just a good resource to talk through financial stressors or changes in your support system, even changes if you need to move and things like that. Really just a good support system for you to help work through any issues that come up. Next, you're going to meet with our registered dietitian. She will go through all of your lab work as well as height and weight and things like that. She may recommend, based on your lab work, for some different supplements. She will also talk you through, your normal diet and see if there are any adjustments that need to be made. She may make recommendations to either help you gain or lose weight, depending on where your BMI is at and where we want it to be. And again, just a good resource for you to help make some healthy life changes to really get your body in the best shape possible before surgery. You will also meet with our financial coordinator. They are going to go through all of your current insurance options that you have, make sure that you have adequate insurance coverage for not only the transplant, but also for all of the medications you'll be taking after transplant. Some of those medications can be very expensive and you wouldn't want to pay for those out of pocket. So she will review everything that you have in place, make any recommendations that she thinks may need to be made either before transplant or things like that. You definitely want to have good communication with her. If you want to change your insurance policies, if you have any lapses in insurance or changes, things like that happen, whenever possible, have her review those changes before they go into effect to make sure you would still be covered. If things are out of your control, you'd want her to take a review and make sure that transplant is still an option for you as well. At Michigan Medicine, we have a list of some certain considerations that we take into account when making our decision. In general, we start our evaluations at 65 or younger, and generally we transplant up until age 70. Another really strict one that we follow, we do want you to maintain a 450 feet 6-minute hall walk, which you will continue to do as part of your follow-up with your pulmonologist. Whenever possible, we like our patients to participate in a pulmonary rehab program. That will help you to maintain this 450 feet and to, again, really be in the best shape possible before surgery. We have really strong data that tells us if you're not able to maintain that 450 feet, that survival rates for transplant are lower. Another strict one that we follow is the BMI range. We require your BMI to be between 18 and 32. When you're under 18 for your BMI, really it makes it more difficult for you to recover from transplant. And then once your BMI is over 32, it again can make the surgery very difficult. It makes it harder for the old lungs to come out, for the new lungs to go in, and things along the lines of the specifics of surgery. But really, it can prolong the surgery, and the longer your surgery is, the higher chance there are of complications as well. Some other big ones, we do ask you to stop any type of nicotine products, so no smoking, vaping, chewing, patches, or gum, to abstain from any type of substances, including marijuana. Then if you have any type of alcohol abuse history, we do ask you to abstain from alcohol as well. And then everything else really kind of comes on a case-by-case basis. We look at all of your testing for every other part of your body and make sure there aren't really other problems going on with other organs, including history of cancer, things like that. We would like you to be cancer-free for at least 5 years. Skin cancer can be a little bit shorter. And again, depending on specific types of cancer, there are some exceptions. But really, we look at your full history of any other medical issues, things like that. Previous chest surgery or radiation could prevent you from getting a lung transplant, or some specific organisms and things like that if you've had specific pneumonias in the past. But really, like I said, we go through and look through each part of your evaluation and then determine if you are a candidate for transplant. We are going to need some extensive testing while you're in the evaluation process to really be able to make our decision, but also to be able to place you on the list. There is a list of testing that needs to be done at Michigan Medicine, and also a list of testing you will be provided with that needs to be done with your local primary care provider. With your local provider, it's really updating that basic health stuff that you should be doing anyways. So for women, your pap smears and mammograms, you want to stay up to date on those. Everyone needs to have bone densities done. Your medications after transplant can be very difficult on your bones, so we want to start treatment for that if needed before transplant. You do need to get clearance from your dentist. You're not able to go to the dentist for the first 6 months after transplant, so we want to make sure not only that there's no active infection, but also that you would be able to wait that 6 months after transplant before needing to go back for any type of treatment. And then once you're to the age where you need a colonoscopy, we need to stay up to date on those. If you are under the age for colonoscopy, we'll get a guaiac stool study. And then everyone is required to have a durable power of attorney on file with us before being listed for transplant. The pre-coordinators will help you through all of the testing that needs to be done at Michigan Medicine. You'll continue to follow up with your pulmonologist to get your pulmonary function tests and 6-minute hall walks done. But there are also some chest CTs and x-rays that we need. There's an extensive list of lab work that we need to have done. And then we also do some heart testing, so echoes, heart caths, things like that. Some people who have specific history of esophageal disease or acid reflux and things like that will also require an esophagram and or a 24-hour pH study. Those are studies that specifically tell us about how much acid reflux you have and what the risks for after transplant could be for that.
Okay, so now we're going to take a look at the next phase of the evaluation, which is going to be the surgical eval. So you will see one of our thoracic surgeons. The surgeon that you see for your evaluation may not be the surgeon that performs your actual transplant surgery. And that's very normal. It's because it really just depends on which surgeon is on call the day or night that you are called in for your transplant. But they all work very closely together and will be prepared and understand your case at the time of your surgery. So what the thoracic surgeon does during this evaluation is they review your test results and your imaging studies and discuss the surgical aspects of lung transplant based on your unique case. They're also going to review the risks and benefits of lung transplant and the survival statistics with you. So once you've gone through your medical evaluation and all of that testing and also the surgical evaluation, we can refer you on to our lung transplant evaluation meeting. This is a multidisciplinary team, meaning it's doctors, our pulmonologists, our surgeons, nurses, social workers, dietitians. Our entire team looks at a full review of your individual case and will make a recommendation of whether or not you could benefit from lung transplant and if you meet the criteria to be placed on the wait list. It's important to remember that not everyone can be placed on the wait list for new lungs. There just aren't enough lungs to go around for everyone that needs them. And so we have to make a very careful decision about patients that are going to be good candidates to receive this very rare resource. Sometimes we review a case and a patient is too well. This means that maybe their chances at survival are greater without a transplant at this time than with a transplant. If this is the case for you, your pulmonologist would continue to provide you the best care possible. And also, we may consider you for transplant in the future. We continue to monitor your progress. And if you started to decline, we could potentially evaluate again. Sometimes patients are too sick. And this can happen if maybe someone's disease progressed very quickly, or if they're already at the point where they are too weak to have a successful surgery. A lot of times this means that either the risk of complications are too high or the chances of a successful surgery are too low. And so what can happen if we transplant at this point is we could actually reduce or decrease someone's quality of life as opposed to give them a better quality of life. Because lung transplant surgery is a very big surgery. It can be hard on the body. And if you're not strong enough to recover from it, it can make you even more sick. And like we said earlier, our goal is to improve your quality of life. And so we definitely would not want to proceed if someone was too sick to have a good outcome. If this is the case, your pulmonologist will provide you the best care possible, and they may refer you on to some palliative treatments. Sometimes if someone is too sick or they have multiple medical conditions that impact lung transplant or make lung transplant more complicated, we may refer you on to another center that maybe specializes in your unique case. Each transplant center has their own unique areas of expertise and past experiences. And so sometimes if you're not a candidate with us, you may be a candidate elsewhere. Sometimes our committee reviews your case and we determine we need more testing or more information to make an informed decision. And so we would have you go and get that testing done. Once you complete it, we'd bring you back to be presented at our committee and make a decision then. Sometimes we approve patients to list and we determine they would be a good candidate for a lung transplant. At that time, the committee will determine whether or not you can be listed for a single lung transplant or a double lung transplant, or maybe either. We'll discuss what that means on the next slide, but you will be notified of the decision regardless of what it is. And if you are approved to be listed for lung transplant, we will submit for insurance authorization to list you. When you are placed on the lung transplant waitlist, you will be listed for either a double lung transplant, a single lung transplant, or either. A double lung transplant is when both of your badly diseased lungs are removed and 2 new lungs from a donor are transplanted to you. Some patients cannot receive anything but a double lung transplant based on their disease type. Some patients have the opportunity to receive a single lung transplant. Single lung transplant recipients can have normal lung function and activity with a single lung transplant. When a patient is listed for a single lung transplant, they may be listed specifically for a right lung transplant or a left lung transplant, and sometimes they can receive either. If your right lung is removed, then the right lung from a donor will be transplanted to you. If your left lung is removed, then the left lung from a donor will be transplanted to you. The lung that is not transplanted will remain inside of your chest. You will have 1 donor lung and 1 native lung. The determination for whether or not you can receive a single or double lung transplant is based on your specific disease, your current medical condition, and your medical history. Sometimes patients are able to receive either a double lung transplant or a single lung transplant, and so they will be listed for a double or single lung transplant. Sometimes when we do this, this enables our patients to be transplanted sooner because they have more options. The determination for which type of transplant you will receive will be made at our evaluation meeting by our pulmonologists and surgeons. So let's talk about once you're approved for transplant, being placed on the wait list. There are more people who need a lung transplant than can get one. There just aren't enough suitable donors. Donor organs must be allocated very carefully and fairly, so there is a waiting list. Prior to May 2005, the wait list was based on time, meaning patients that had been waiting the longest for lungs were at the top of the list, and patients who had just been added to the list recently were at the bottom. It did not take into account a patient's disease type or how sick they were, and it did not consider how much time they had to wait. This was a problem because patients with slowly progressing diseases, such as COPD and emphysema, were being transplanted because they were able to wait the average 2 to 3 year waiting period to get lungs. Patients with quickly progressing diseases, such as IPF and pulmonary hypertension, were unable to wait the average 2 to 3 year waiting period, and so they were not being transplanted. This discrepancy between who was receiving transplants and disease type was a problem, and so they created the lung allocation score. This is a score between 0 and 100, 0 being a healthy individual and 100 being a very sick individual, that is based on a very long calculation that takes into account disease type, the results of your physical exam and diagnostic testing, and reflects how sick you are. It also takes into account your likelihood of having a successful transplant. The way the list works is patients with the highest scores go to the top of the list, and patients with the lowest scores are at the bottom of the list. Patients that are waiting for a lung transplant at home generally have a score between 30 and 40. The closer the patient gets to 40, the more competitive their score becomes. Patients that are waiting for lungs in the hospital on a high flow nasal cannula, meaning additional oxygen that you can't receive at home, often have scores between 50 and 60. Patients that are waiting in the hospital on life support, such as mechanical ventilation or ECMO, generally have a score between 80 and 90. Sometimes a patient becomes so weak or debilitated that their score begins to drop. So it is really about finding that sweet spot between being sick enough for transplant, but not so sick that your score will start to fall. So you're listed for transplant. Now what? It's really important that you're not only physically ready for transplant, but also mentally ready. The call for a new set of lungs could come at any time. It can come in the middle of the night. It can come during the day, holidays, weekends, but the moment you are listed, you have the potential to be matched with a donor. And we take your spot on the wait list very seriously. Your spot on the wait list is taking away from someone else. So when we list you for transplant, it's under the understanding that you will come in when we call you. If patients refuse transplant when we call them in because they have a moment of panic or they're not ready, it may lead to being removed from the list, right? Because we don't want to take away someone else's spot. Sometimes the call comes a couple days after you're listed. Sometimes it comes a week, months, but it could be years. It's impossible for us to predict when you'll be called in for transplant.
Let's talk about what it means to match with a donor. The availability of donors really depends on the limited number of donors. Individuals and families have to be willing to donate, and not everyone is. And then on top of that, even when someone is willing to donate, the lungs have to be suitable. So lungs are really a very fragile organ. They're one of our only organs that gets exposed to outside elements because you're constantly breathing in whatever is around you. So there's an increased chance for you to breathe in either bacteria and things like that and causing a pneumonia, or to breathe in other contaminants that could damage the lungs, such as smoke or something like that. So even when a donor can potentially donate liver or kidneys or even heart, they're not always a suitable donor for lungs. We have to look at the lungs that are going to be most suitable for our recipients. Specifically for matching up with you, it depends on your blood type. Some blood types are more rare than others. It also depends on your size. We need a relatively same height and weight to match up with yours as the donors to make sure that the lungs are a similar size. We also look at extensive blood work to see if you have any antibodies in your blood, and that comes with all of your evaluation blood work testing. If you have antibodies in your blood, which a lot of times increase with pregnancies or the amount of blood transfusions you've had, we have to look at specifically those antibodies in the donor as well. Make sure that not too many of them match to help decrease your chances of rejection. It also depends on your score, of course, like Danielle was mentioning. The higher your score, the higher you are on the list. So the more likely you hopefully will match with a good donor. And then also different transplant centers have different criteria, mostly along the lines of maybe how old of a donor they would take in relation to how old the recipient is. It also depends on what you're listed for. So as Danielle was mentioning, we could list you for either a double or for potentially a single or for either. Sometimes whatever makes a donor could damage one lung and not the other. So maybe only the right lung is available. If you're the only one on that list that needs just a right lung, then you could potentially match with that donor when no one else is able to. So that really just opens up potentially some more donors for you as well. And then it also depends on the availability of donors within your specific area. So there's only so far that we can travel to really make transplant done in a reasonable amount of time. So it depends on if you live towards a more populated area of the United States or not, could impact how many donors are available to you as well. This is kind of an example of how lungs are allocated out. In the past, they were given within state boundaries first. So if a donor became available at Michigan Medicine, for example, that donor would be matched up with all of the recipients within Michigan that were a good match based on blood and height and weight and things like that. And then if no one wanted them or no one was a good match within Michigan, it would move to surrounding states. Now, however, they do kind of eliminate state boundaries. So they go by these nautical mile ranges. So this is, again, an example. If the donor was at Michigan Medicine, it would first go out to all of the recipients within a 250-mile radius. From there, it goes to a 500-mile radius and then a 1,000-mile radius. Really, this has just opened up more donors for people who are very, very sick. For instance, a very sick individual in Michigan could potentially get lungs from Ohio that previously were not available to us because they stayed within Ohio state boundaries first, and then vice versa. So someone who is sicker in Ohio could potentially take lungs from Michigan for the same reason. So the sickest people getting the lungs sooner. Once you're on the list, you do have the right to be multiple listed or to be registered for transplant at 2 or more transplant hospitals. So there are, as you can imagine, some advantages and disadvantages to this system. So if you're on 2 transplant lists, especially if the transplant centers are far enough away from each other that they reach potentially different donors within that 250-mile radius first kind of circle, it can potentially give you access to more donors, and with that could increase your chances of receiving a donor sooner and also potentially shorten your waiting times on the list. So there can be some advantages for matching up better or sooner, but there is also the other side of things where you would not only need to be accepted by both centers for evaluation and for transplant, but also your insurance company would have to approve both centers, and for you to be listed at both places, there is a need to finish both evaluations. Some of our testing can be shared between centers, but a lot of centers want their own testing to be done at their own center. There's also double the follow-up. So before transplant, you would have to continue to follow up with pulmonologists at both centers. And then you would also have the travel time and expenses of going back and forth to both of those centers. In addition to that, whatever center accepts the organ would be the one that actually does the surgery. And that would be the center that does your lifelong follow-up after transplant. So once you're on the list, what are your responsibilities? You must stay within a 4-hour radius of Michigan Medicine. And that really has to do with we can't get you in for transplant soon enough once you get out of that radius. It just becomes too difficult. A lot of our cases move very quickly, and we would want you to be able to get to Michigan Medicine as soon as possible. You are going to continue to have routine follow-up with your pulmonologist about every 3 to 4 months. And with that, you're going to have continued pulmonary function testing and hall walk testing, as well as some routine blood work that we continue to get to keep you on the list as well. We need you to stay up to date on all of your testing. So all of those dental visits, the pap smears and mammograms, the colonoscopies, all of that kind of stuff, we want you to stay up to date on. And we'll also help you stay up to date on chest x-rays and CT scans. As we mentioned before, you have to maintain that 450 feet in 6 minutes. So we'll continue to watch your hall walk distances and make sure that you are able to keep up with that. And then, as I mentioned before, we do like you to participate in some type of pulmonary rehab program whenever possible, just to continue to be in the best shape for surgery. You definitely want to notify the transplant coordinators if there are any type of social life changes, any changes to your caregiver support or things like that, if there's any health or medication changes while you're on the list. And then also if your breathing gets worse and there's any changes in how much oxygen you're using. All of these things can really have an impact in your score. So we would definitely want you to keep up to date with that. It really is your responsibility to maintain the best health you can before transplant to really give you the best chance at a good surgery and good follow-up afterwards. Once you are placed on the transplant list, we sometimes come across situations where you need to be placed on hold for short periods of time. Being placed on hold means that you are still listed for transplant, but you're not going to match with any donors during the time that you are on hold. Usually this comes up if someone needs to travel outside of the 4-hour radius of Michigan Medicine. You call and let the pre-transplant coordinators know that you need to travel for whatever reason, and we can place you on hold. As soon as you're back within that 4-hour radius, you can give us a call back and let us know that you're back, and we can go ahead and reactivate you on the list. Some other situations where you need to be placed on hold could be either if you are sick, and then, for any type of reason that you're sick, definitely let the coordinators know. If you're placed on any type of antibiotic, this makes it difficult for the actual transplant surgery. It can make your recovery more difficult. And with that, if you're on any increased doses of prednisone, more than 20 milligrams per day, increased doses of prednisone can make your healing from the transplant surgery more difficult. So we wouldn't want to transplant you during any time when you're on more than 20 milligrams per day. Additionally, if you're hospitalized outside of Michigan Medicine, so any type of emergency or anything that happens while you're on the list, we absolutely would like you to go to whatever emergency department is closest to you and get the care that you need as soon as possible. When you are at an outside facility, you want to let them know as soon as you get there, as soon as you possibly can, that you are listed for transplant with Michigan Medicine and that you need to be transferred to Michigan Medicine as soon as you can. Sometimes they need to keep you and stabilize your care and then transfer you over to Michigan Medicine. Sometimes they're able to do an emergency room to emergency room transfer very quickly. So let them know as soon as you can that you need to be transferred. If you do need to stay there for a while and be stabilized before you're able to transfer over to Michigan Medicine, you're going to want to have someone call the pre-transplant coordinators and let them know that you are hospitalized somewhere else. We will place you on hold until you're able to be transferred, and our transplant physicians can do their own assessment and see if you would still be a transplant candidate at that time or if you need to remain on hold. If you are hospitalized at Michigan Medicine, we are able to see you every day. Our physicians are able to keep up to date on everything that's happening with you, and they are able to make the decision of if you are able to be active for transplant while you're hospitalized, or as soon as you possibly can be reactivated. They'll make that decision and let the transplant coordinators know. So whenever possible, we do want you to be hospitalized at Michigan Medicine. Additionally, like we kind of talked about earlier, anytime you have any changes or lapses in insurance, if you don't have coverage for some reason, we do want to place you on hold. We wouldn't want you to pay for anything transplant related out of pocket or pay for the least amount out of pocket as possible. So we would want you to have good insurance coverage at all times. If you need to make some changes and things like that, let the coordinators know, let the financial coordinator know, and we'll place you on hold during that transition period. If you lose any of your support or caregivers, we may need to place you on hold until we're able to figure out a better care support plan for you and make sure you have adequate support to get through the transplant surgery and the recovery afterwards. And then as needed, as things come up for you in your life, if an adult child is getting married or things like that, you may need to have a week or two off to kind of just get through the wedding and things and not come in for transplant during that time. Sometimes you're just not going to be available for transplant for different life events that happen and things like that. So you can always call and talk to the transplant coordinators, tell them about whatever situation you have going on, and we can definitely help you through those situations. Once you're on the list, there is also the chance for you to be removed from the list. And this generally comes with if you are repeatedly missing your appointments, if you won't take your medications or follow the lung transplant team's recommendations, if you won't get your lab testing or your routine follow-up testing, things like that. Not only does it affect your waitlist score, once those things become expired, it does drop your score, makes you lower on the list, but also we need you to prove that you're going to follow up with your care after transplant as well. So if you're not following up with that care before transplant, it may be a reason for us to remove you from the list. Additionally, if you are not following our substance abuse policy, we continue to test for that the entire time you are in the evaluation process and also once you're listed. So if any of that comes back positive, we may need to remove you from the list. And then also for those insurance lapses or things, if we're not able to clear you for transplant again and your new insurance just doesn't cover transplant, we may need to remove you from the list. Or if your social support changes and we're not able to find a good replacement or anyone that's really going to be able to support you during transplant, we may need to remove you from the list. And then lastly, if you just deteriorate too much. So if you get too sick, you're not strong enough for transplant, something develops in another organ, or if you're not able to maintain that 450 feet in 6 minutes, you just get too sick, too debilitated, we may need to remove you from the list for that reason as well. Once you're on the list, sometimes our patients, when they're waiting, they're not able to maintain enough oxygen with the resources that they have at home. So they're just getting too sick, their lungs can't do the work, and they just really need more support than what they're able to maintain at home. Sometimes they need to come and wait for lungs in the hospital. They can either require some type of high flow oxygen, so just increased oxygen through the nose, or they may need one of these two or invasive types of support. So you could potentially need mechanical ventilation, which is a breathing tube that would go in and would do the work of breathing for you and give you the oxygen that you need. Or there's the potential for needing ECMO, which is a full system that takes the blood out of your body, it oxygenates it, and then puts it back into your body and circulates it for you, kind of bypassing the lungs altogether and really providing your body with the oxygen that it needs. And in all of these situations, if you're waiting for lungs in the hospital, we continue to make you maintain the physical abilities. So we continue to have you walk the 450 feet in 6 minutes and work with physical therapy to really make sure you're in the best place possible before transplant. Some of our frequently asked questions when you're waiting for lungs: how long will you wait for lungs? You know, it's impossible for us to really guess for that. It depends a lot, like we mentioned, on your blood type, your score, and your actual sizing to really get the best donor for you. As Danielle mentioned earlier, you could wait for a few hours once we list you, or you could wait for several years. It's just really, there's no way for us to really guess that. When will you be called in for transplant? It could be any time, day or night. A lot of times we're calling our patients in overnight, but again, hard for us to predict. It all depends on how each case is going. Why are you waiting so long for lungs? Again, really depends on just getting suitable donors for your specific case, either with sizing, with antibody issues, or just with whatever donors have matched with you if they've been bad donors or things like that. So all pretty case specific, but we definitely are trying to find the best donor for you possible. Some of our smaller patients ask us sometimes, if a donor is too big, can the lungs be cut down to fit into your body? They are able to cut lungs down to a certain extent, but if they start to cut them down too much, they become less functional. They also need to match up not only the blood vessels, but also the airways themselves. So generally, if lungs are too big for you, then those things may be too big for you as well. So the surgeons will look at all of that with the donors and really assess to see if it's a correct size for you or not. And then last, unfortunately, what if lungs never become available to you? So we've kind of mentioned this before, there aren't enough lungs for everyone who needs them. So sometimes you don't make it to transplant if you become too debilitated or things like that. Like I mentioned, we may need to remove you from the list. Some people just get way too sick too quickly and unfortunately do not have time to match with someone. So that is a very real part of lung transplant as well.
Let's talk about our organ donors. The donors are brain dead donors, meaning there's confirmation of no brain activity, but they are being maintained on life support, such as the mechanical ventilation. Donors undergo extensive medical and surgical history, both based on chart reviews and questionnaires from the donor's family. Physical exam is also conducted and includes extensive testing such as blood work, ABGs, chest x-rays, chest CT scans, bronchoscopies, and sputum and blood cultures, which check for the existence of any current infections. And then we also look at testing for antibodies, looking for previous infectious diseases or chronic diseases such as hepatitis B and C and HIV. When we do that testing, we will not accept a donor that has hepatitis C or HIV. We will often consider hepatitis B donors if they have had the infection in the past and it's not a current or acute infection. That's based on a case-by-case scenario. But for hepatitis C and HIV, if the patient has tested positive, currently we would not consider that donor. All donor information is completely confidential and cannot be shared with you. We will mix donor recipient gender and race, meaning you could receive a donor that is a different race from you. And if you are female, you could receive lungs from a male donor and vice versa. This is a good time to talk about connecting with your donor family after transplant. We do not allow any communication or contact between the recipient and the donor's family until 1 year after transplant. You will be able to reach out to your donor's family if you would like to through our state OPO or Organ Procurement Organization. Michigan's OPO is Gift of Life. Generally, contact with your donor's family is done primarily by letter and can progress as both are willing. Both the donor's family and you must be willing to communicate in order for that to happen. It must be a mutual agreement. If one side is not ready to connect with the other, then there cannot be any communication.
So what happens when lungs become available for you? The transplant coordinator will call you. We only have 1 hour to contact you. We cannot leave any messages or voicemails. We have to get in contact with you specifically, and that is a UNOS regulation that we are not allowed to leave voicemails. So once you are on the list, you cannot screen any of your calls. We understand that there are a lot of telemarketing calls and things like that these days, but the on-call coordinators do take on-call from home with their personal cell phones, so it won't always show up as a Michigan Medicine number or things like that. So you would want to answer any call that comes through to your phone because it could be your call for transplant. You must also supply us with current phone numbers of not only you, but also anyone else that may be able to get in contact with you in the event that we're not able to get through to you. We do use every possible second of that hour to get in contact with you. We call you and whoever else is on your support team. We call everybody back to back to back. Majority of the time we get through to you or your second person right away, but there are times where we have to go to multiple people on the list. So definitely give us a good list of people that would be able to get in contact with you. Preparing for the call, we want you to be ready for transplant at all times. This call could come anytime, day or night. We do want you to have a go bag ready along with transportation. Are obviously going to want your cell phone and any chargers you might need. You really don't need a whole lot. Your first few days will be in the ICU, but any of your caregivers that are there at the hospital may need snacks, change of clothes, chargers for themselves, things like that. So definitely, anything that your caregivers might need during this time. Additionally, we do want you to bring the education book that you receive at the beginning of evaluation as well. This will help with some of your education that you get before you go home. Additionally, we want you to have a plan in place for any dependents or any pets at home, someone that's going to be able to take care of them outside of your caregiver who's going to hopefully be at the hospital with you. And then you also need a plan for your home and your financials. So sharing any passwords or accounts, things like that need to happen before you go into the hospital. So those things can all be taken care of while you're away from home. And then as we've mentioned, stay within that 4-hour radius of Michigan Medicine, or in extenuating circumstances, have some type of transportation arranged that can get you here within that amount of time. Getting the call, like I said, it can come anytime, day or night. We'll let you know that the surgeon has accepted lungs for you. We'll tell you at that point to stop eating or drinking. We're going to make sure that you are feeling healthy, no new sickness, no new antibiotics, things like that. We're going to make sure you're within that 4-hour radius of Michigan Medicine, and we're going to work with you to see how quickly you think you can actually get to Michigan Medicine. Like I said, some of our cases move really, really quickly. We need you to get here as soon as possible. And really get to the OR as soon as possible. Some of our other cases allow for a little bit more time. So depending on how much time we have to play around with, we want to see how soon you're able to get to the hospital. So at the same time, we have you at our hospital ready to get lungs. We are sending out a team of surgeons and organ procurement specialists to the donor. As I mentioned, some of them go very quickly. Some of them are kind of hurry up and wait. We have you get all into the hospital and you're waiting around forever until we actually go to the OR. The team of surgeons that we send out will take an actual look at the lungs themselves. They will do their own scope or bronchoscopy to look down into the lungs and make sure that they do look like suitable lungs for transplant. Occasionally, when we get there and actually open up the donor, we realize that these lungs are not suitable for transplant. So occasionally they open up and they find cancer in another organ or things like that, or that the lungs are really full of fluid or something like that, and they just don't look like good lungs for transplant. That is what we call a dry run case. So we have you in the hospital and totally ready to go, but unfortunately we have to cancel everything and send you home without a transplant. So it is not very common, but it is a possibility when you do get called in for a transplant. We travel up to 1,500 miles, which pretty much gets us the entire East Coast down into Florida, into Texas, and about as far west as the Rocky Mountains, so out to Colorado and Utah. Our goal with that is to have you here in the OR, get you as ready for those lungs as possible so that the time we clamp the donor's blood at that hospital and fly them back or drive them back from wherever they're at, as soon as we get back, we're ready to put those into you so that when we take the clamp off of the blood at you, those lungs have been without blood for about 4 to 6 hours or less. Really, our goal is to have those in within 6 hours. So, like I said, we have you as prepped and ready for surgery as possible. As soon as we know that those lungs look good is when we would put you to sleep and actually start your surgery. When you get admitted to the hospital for transplant, you're going to go into the cardiovascular ICU. They're going to get your full history, physical, get your labs drawn. They usually get a chest x-ray. Occasionally they need to get an echo or something like that, but they'll get you totally prepped and ready for surgery. So during the surgery and sometimes before surgery, they will place some different lines and tubes to assist us with your care. They may place some IV lines either within your arms or hand potentially. They may also place a pulmonary artery catheter, and it's a large IV that goes into more of the neck area. That allows us to get some different heart pressure readings and also allows us to infuse medication very quickly. They may also place an arterial line, which is a line that goes into your wrist. That allows us to get a constant blood pressure reading and also allows us to take blood samples as often as needed without continuing to poke you for them. During the actual surgery, after they put you to sleep, they will place an endotracheal tube, which is the tube that will actually do the breathing for you during and right after surgery. And then they will also place during surgery a nasogastric tube. And that tube really helps to suction any contents out of the stomach and to help keep the stomach empty so none of those contents can come back up and into your lungs. And then during surgery, they will also place a urinary catheter to help collect any urine that is collecting within your bladder during surgery as well. So during surgery, there's a whole team monitoring everything that's going on. The surgeon is going to start the operation by making an incision on your chest. For a single lung transplant, they do a thoracotomy approach, which is an incision starting in your side and going into your back. And for a double lung transplant, we have a picture on the next slide, which I'll show you in a minute, but they would do what's called a clamshell approach, which goes all the way across the front. During surgery, they may also need to use a cardiopulmonary bypass machine, and that is going to take the blood out of your body, oxygenate it, and then circulate it throughout your body as needed. Again, depending on a case-by-case basis of if you're getting double lungs or single lung, and really how well your heart is handling the stress of the operation. Sometimes they just need to bypass the whole system just to keep the pressures down in the heart. Single lung transplants usually range in about a 6 to 8 hour approximate range. Double lung transplants usually take more like 8 to 10 hours, and that is with no complications at all. If we start developing complications or you have a very just complicated case and things like that in general, it is not uncommon for those to extend and be even longer. So like I said, our next slide, this is the clamshell incision, an actual real life example of what a double lung incision looks like. And then there's also, you can see some chest tubes and IV lines and things like that as well. So after surgery, you would come out of surgery with, depending on if you get a double or single lung, anywhere from 2 to 6 chest tubes, or some of those may be replaced by these smaller JP bulb drains. Again, just really depending on surgeon preference and how much fluid is actually accumulating around your lungs. We're trying to drain all of that fluid out to keep those lungs as open and as much air in them as possible.
Once you are discharged from your surgery, you will be sent to the ICU to recover and learn to live with your new lungs. So once you're in the ICU, we're going to work to try to extubate you, meaning we're going to remove that breathing tube. Sometimes we can get this done in about a day. Sometimes it takes longer than that. The sooner that we can remove the breathing tube, the better. And we hope to prevent a prolonged course or many days on that breathing tube. Once the tube is removed, we can also remove the NG tube or the nasogastric tube as well. And we'll start you on kind of a minimal diet of just like liquids and very easy to swallow foods, and hopefully progress you to a full diet. Progressing to a full diet is going to be on a case-by-case scenario. Some patients require a feeding tube long-term after transplant. We'll work to remove your test tubes as soon as possible. Generally, this is once your lungs have had a little time to heal and there's no risk at your lung collapsing once the chest tube is removed. The pulmonary artery catheter that we place to monitor your heart and to infuse fluids through during the operating procedure and while you're in the ICU, that will be removed before you go to what we call the floor or the general level of care nursing unit. Your pain will be controlled with sedation while you are intubated, while you have that breathing tube in. Before we extubate you, we'll place an epidural catheter, much like the catheter and pain control that we use for women in labor. We're going to give you an epidural just a little bit higher up so that it helps to control that pain and numb that area around the site of your incision. Once we kind of wean you off the epidural, we will transition you to maybe IV medications and oral pain medications. We'll work to wean you off those narcotics after you discharge home. While you are admitted to the hospital, no sick visitors are allowed, and all of your visitors will be required to wear masks because you will be highly immunosuppressed to protect your lungs from rejection. On average, the length of stay without complications is about 10 to 14 days. With complications, that can become a much longer length of stay. We've had patients that have had to stay in the hospital for a month, 2 months, if not longer. We're going to do everything we can to reduce your risk of complications and get you home as soon as possible. Once you discharge, you will be seen by a visiting nurse a couple times a week. What are your jobs after surgery? It is really important that you are dedicated to making progress and recovering after surgery. Your motivation is going to mean everything for you in terms of how quickly you recover. Very important that you are motivated to get up in a chair and walk very quickly after surgery. Sometimes it may seem like it's too soon, but the sooner that you can get up, sitting in a chair and walking around the hospital or walking around the nursing unit, the better. It'll prevent you developing pneumonia and blood clots in your legs. And it will help to exercise your new lungs. We'll make sure that we're controlling your pain medication to a tolerable level so that we can get you up and active as soon as possible. Another way that you'll exercise your new lungs is by using your incentive spirometer. If you've never used one before, our nurses and respiratory therapists will teach you how to use it. It keeps your lungs expanded and prevents, again, pneumonia. We'll teach you how to take care of your new incision and your drains. And we will also teach you about your new medications and how to take them on your own. Like all surgeries, lung transplant does come with some potential risks and complications. Bleeding can occur along the staple line after the operation. If this happens, blood can sometimes build up around the lung and you may have to go back to the operating room to have it removed. Sometimes your lungs may have trouble inflating, or you can develop atelectasis, which is just fluid buildup around the bases of the lungs. Lungs are very similar to a balloon in that when you're blowing up a balloon, the end of the balloon furthest away from the hole will inflate last, and it will be the most difficult to inflate. Lungs are the same. So the most dependent bases of your lungs are furthest away from your airways, your nose and mouth, will be the most difficult to inflate or deliver air to, and probably inflate the latest. Ways that we can prevent that, again, are with the incentive spirometer and getting up and walking. But sometimes if that fluid stays around those bases of the lungs, you can develop pneumonia. Sometimes if we remove the chest tube a little too earlier, we think your lungs are ready, but they're not quite ready yet, and we remove the chest tube, you may develop a pneumothorax, which is a collapsed lung. If this happens, we'll replace the chest tube and help to expand that lung again and try to remove it at a later time when your lungs are ready. Sometimes our patients will develop an irregular heart rate because of the closeness of the lungs to the heart during the operation, and could potentially develop low blood pressure or high blood pressure. You could develop elevated blood sugars, or you could even develop a blood clot. And sometimes our patients have kidney problems. Some of these complications may be acute, meaning they happen during your hospital stay and they're corrected. Sometimes they're more longer lasting, or they become what we call chronic conditions. You may become a diabetic requiring insulin if we cannot control your blood sugars. You may require dialysis if your kidneys are damaged or cannot recover from the surgery or the medications you're on. We will do everything in our power to control and to correct the complications that arise as they come. You will be monitored very closely in our ICU and in our general care unit after your transplant to correct any issues that arise. And we will work with you to limit the effect of any complications lifelong after transplant as well. But let's talk about what recovering at home will look like for about the first 6 months after transplant. So when you discharge home, you will have a visiting nurse that comes a couple of times a week. They're going to take your vital signs, help you with your medications. They may draw some labs. They're going to inspect your incision for healing, and they're going to help you just navigate your new life around the home. However, it is very important that you have a support team outside of that visiting nurse. Like Misha mentioned earlier, you are required to have at least one support person that's available 24/7 for that first month to help you navigate life after transplant. A lot of this is because you're going to have some activity restrictions, but it's also because that time after transplant can be a period of some very labile emotions or just anxiety, adjusting to your new lungs. And we want someone there to reassure you and calm you down if you are ever to have a moment of maybe anxiety or heightened emotions. Your nurse will also help you with your JP drains and just your activity around your home as well. Biggest part of your follow-up care after the first 6 months is going to be a lot of visits with your pulmonologist and trips to our university. And the main focus is preventing infection and rejection. So it is a big commitment. Right after your transplant, you're going to have a lot of trips to our hospital. You'll see your surgeon that performed your transplant approximately 1 month after surgery, and you will have follow-up with your pulmonologist very frequently. Generally, the first visit with your pulmonologist after discharge is 1 week after discharge, which is usually about 3 weeks after the actual transplant event. Then you'll have a visit at 6 weeks, 3 months, 6 months, and 1 year after transplant. Sometimes visits happen more frequently as needed. During those visits with your pulmonologist, they will adjust your medications, help you wean from your pain medications, monitor your wound healing. You will have routine bronchoscopies and PFTs or pulmonary function tests, chest x-rays, and CT scans. We would also encourage you to participate in pulmonary rehab to continue to exercise your new lungs. You'll have a lot of lab work that you do as well, both during your visits and sometimes at home. But the main reason that we do all of this medical care and all of this follow-up is to prevent rejection and infection. We want to recognize it early and treat it before it becomes a problem. During this initial post-lung transplant period, you will meet your post-transplant nurse coordinator. These nurses are your go-to person for any questions or concerns after discharge. They work side by side with your pulmonologist to help manage all of your care, adjust your medications, help to monitor your lab work, and they are your lifelong coordinator for all of your transplant care. You will become very close with this nurse, and they are going to be really your biggest communicator, right, for any issues or concerns that you have after your transplant.
So one of our biggest challenges after transplant is to really balance out infection and rejection. So we're going to take a closer look at both of these. Really, our main goal is to give you enough medication that we stop your body from rejecting these new organs, but also we don't want to give you too much medication that your body starts developing too many infections either. So as you'll see, kind of lifelong, we're going to be balancing out your medications, your different lifestyle activities and things like that. Really just trying to keep a good balance between the two so that one doesn't get too far out from the other. Additionally, we want to really balance out your medications. Too much immunosuppression medication can also cause a lot of side effects, so we want to decrease those as much as possible. The signs for infection and rejection really can be very similar and can kind of take some work for us to develop which one actually you're suffering from, or if you're suffering from either. So we continue to look at all of your side effects and any changes that happen within your course of stay, and then to treat you accordingly. Rejection is the body's natural response to any type of foreign object. That includes your new lungs. Rejection can cause damage to the lungs, and it's basically your body attacking those foreign objects. Lung transplant recipients do require lifelong immunosuppression medication that kind of helps quiet your body down so that you don't attack those new organs. We do use a combination of 3 medications in lower doses to keep you from rejecting and to help balance out the side effects from medications as well. You will continue at your bronchoscopies to get different biopsies taken to help look for any type of rejection. And if rejection is discovered during one of those biopsies, it helps us to determine the severity of that rejection. You're most at risk for rejection in the first 6 months after transplant, really until we get your body kind of quieted down, all of your medications within a good range and things like that. There can be episodes of acute rejection or really sudden rejection that we can treat with some either increased medications or things like that, just adjustments to your current medication, or potentially with different hospital stays and things like that. Depending on exactly your specific case. But there's also chronic rejection, which is kind of rejection that continues to go on for longer periods of time. A lot of times this can happen if you continue to not take your medications, or if you are taking your medications incorrectly, or sometimes an infection can lead to an episode of rejection as well. So as I said, we're going to keep balancing those two out. Infection would basically mean like a pneumonia or something like that, either bacterial, fungal, or viral within the lungs, but also the medications that we have you on for suppressing that immune system. If we have you on too much of that medication, it increases your risk for these infections to happen and really can increase your risk of any type of infection throughout your whole body. This would also be treated with either IV, oral, or inhaled medications. Sometimes can be done as an outpatient, but also sometimes may need to be done at the hospital, requiring you to stay with us for a little bit of time. Early identification of infection and rejection really is the key. This is a representation of one of our actual patients. You can see the pulmonary function testing here really increased after transplant and kind of plateaued generally over time, except for these 2 major dips in function that you can see there. The first dip we saw actually was an episode of rejection. We first saw it in the pulmonary function test, had a bronchoscopy done after that, and then found the rejection. Similarly, the second episode was an episode of infection. Same thing, we saw it in the pulmonary function test first, did some further investigation, found that it was infection. In both cases, there were no symptoms or anything like that happening. So really this pulmonary function test was our first crucial piece of evidence that something was going on, and really allowed us to step in and correct the problem as soon as possible. So keeping up with your pulmonologist visits and all of your testing is absolutely crucial after transplant. The best way for us to really prevent any type of infection and rejection is to really avoid sick people and crowds. You're going to want to continue to practice good hand washing, especially whenever you're out in public and before you eat and things like that. You're going to want to wear a mask in public for the first 3 months, or lifelong near any type of construction sites, any type of mold or dust. And then anytime you come into the hospital or come into the clinic, until you get to your own private room, you want to wear a mask. Generally, if people wish to return to work or school, you can do that somewhere in the 3 to 6 month range. You would need to be cleared by your pulmonologist to return to work, and they would discuss that with you on a case-by-case basis as well, depending on your occupation and also on how well you've been doing after transplant and things like that, to see how high of a risk it would be for you to return to those places. Additionally, you can continue gardening after transplant, but we ask you to wait at least 6 months before resuming that. And when you do, we want you to wear a mask and gloves and to also avoid any type of compost piles or things that could be rotting and expose you to mold and things like that. We don't want you to share any type of utensils or cups or toothbrushes. Again, just trying to limit your risk of picking up any germs from anyone else. And then, as we said before, we want you to continue to not smoke and to not be around smoke as well. When you go home, you are going to have a little bit of wound care to continue with. Your transplant coordinators will teach you more about this after transplant as well, but you'll continue to look at your incision and notify the team if there's any increased redness, any drainage from the incision, or any tenderness at the incision. You will only do sponge baths until all of your drains are completely removed. And then from there, you'll only do showers until everything is completely healed and you are cleared from your pulmonologist to take a bath or to go swimming. And then we ask you not to go into any type of public hot tubs, again, for the increased risk at picking up germs and infections there. After transplant, you do have some activity restrictions. Specifically, there are lifting restrictions, so no more than 10 pounds for the first 6 weeks, and then no more than 25 pounds for the first 3 months. You'll be cleared from all of that by your pulmonologist as well. No driving for at least 1 month after surgery or while taking any type of narcotic pain medications. Generally, you get cleared for that from that 1 month surgery visit, and it has to do with your ability to be able to twist and turn from side to side to appropriately drive. And also, if you were to be in any type of car accident or things like that, and you were to hit the steering wheel, it could really disrupt a lot of the plating and screws and things like that they need to use for surgery. So definitely wait until you're cleared before that. We ask you not to travel for this first 6 months. Like we said, that first 6 months is really your most fragile time. So we don't want you exposed to any additional germs or infections, things like that. And also, we wouldn't want you to be far away from us if anything were to happen suddenly and you needed medical care. We would want you to be close by so that you could come in and we could check you out for ourselves. And then also no flying until you're cleared by your pulmonologist. This has to do with sometimes during surgery, there are little pockets of air that kind of get trapped within your chest. It's completely normal and will just eventually be reabsorbed by your body. But if any of these pockets continue after transplant and you were to fly, once you get up to altitude, they tend to expand within your chest, and it really causes a medical emergency and an emergency landing of the plane. So you wouldn't want to do that before you're completely cleared by your pulmonologist as well. Again, off limits until cleared by your pulmonologist. Any type of golfing, swimming, discharging of firearms, bowling, any type of contact sports like baseball, basketball, anything like that. Really anything that requires an aggressive swinging or twisting motion. You don't want to open up any of those incisions. You don't want to dislodge any of that plating again or wires, things like that are kind of holding everything in place until everything is really well healed. You just want to kind of lay low. We do, however, want you to be active and to live your life as well after transplant. Really, walking is one of the best things you can do after transplant to get those lungs just going really good and to help prevent pneumonia and things like that. Or riding something like a stationary bike could be a good option for you. Just some of those kind of more low impact, but still active types of activities.
So let's talk about what it looks like to continue with specialized care for life. Lung transplant can be very fragile and unforgiving. And what this means is if you do not take your medications as prescribed or follow the recommendations of your lung transplant team, your lungs could become very sick and they may not survive. All of the medications and instructions we give you are there to protect your lungs and to protect you after your transplant. And the success of your lung transplant is really based on your ability to follow those instructions and to recognize when something is wrong. A lot of our transplant patients say that it's exchanging one medical condition for another. You probably have already recognized that by now. Going through a transplant does not mean that you will be 100% cured. You may have gotten rid of your lung disease, but now you have a lung transplant, and that requires lots of follow-up care with your doctors, lots of medications, and lots of unique transplant treatments like pulmonary function tests, bronchoscopies, and things like that. And so the responsibilities and the amount of interaction with the medical team may not lessen, it may be the same, it may be more. It's very difficult to predict how a specific patient will respond to transplant. Survival statistics change over time. Generally, the 1-year survival rate is about 90%, meaning 9 out of 10 patients are alive 1 year after transplant. Generally the average for the nation. And then this 5-year survival rate is generally around 50%, meaning 5 out of 10 patients have received a lung transplant are alive 5 years after their transplant. These are generally the averages for the nation. Survival statistics do change. So if you would like to access or see the most current statistics for our nation and also broken down by transplant center, please see the UNOS website, unos.org, and then the Scientific Registry of Transplant Recipients also has a very comprehensive breakdown of transplant statistics, and you can visit that at srtr.org. So let's talk about life after transplant. Lifelong, you'll have return visits with your pulmonologist every 3 to 4 months. So this is generally after that first year where you have all of your frequent follow-up visits, you will continue to see your pulmonologist every 3 to 4 months. You'll have lots of prescriptions with refills and insurance authorizations. As Misha mentioned, it's important to avoid sick people and crowds and to practice good hand hygiene. We want you to live your life. So if there's ever a concern for an activity you want to do or somewhere you want to go, just talk with your transplant coordinator and your pulmonologist about whether or not something should be avoided because of your history of transplant. Now, it's all within discretion and taking it case by case. We want you to enjoy your life. If you're someone that in the past liked to run races like 5Ks or marathons, we've had patients participate in those types of things after transplant. And that's a very crowded area, right? So it's really a case by case scenario and depends on how far out you are from transplant and how your lungs are functioning. So although we advise avoiding sick people in crowds, we'll take that on a case-by-case basis and the further you get out from transplant. Another thing, right? If you like to go to concerts, we want you to be able to get back to those types of things. So it's all within reason. And if there's ever a gray area, just reach out to us and we'll figure out whether or not an activity is safe for you. After transplant, any type of NSAID medication will be off limits. This includes medications like Motrin, ibuprofen, Aleve, Advil, and naproxen. Our pharmacist will give you a list of medications that are off limits for you when you discharge home as well. The reason why NSAIDs are off limits is because the medications you'll be on after transplant will interact or affect your kidneys and are excreted through your kidneys, and so are NSAIDs. And so if you're taking both of those at the same time, it can be a lot of stress on your kidneys, and we want to avoid that. We do not require individuals to be completely abstinent from alcohol unless they maybe have had a history of alcohol abuse in the past. However, if you are taking an antifungal medication, you will need to avoid alcohol because of the impact that both the alcohol and the medications can have on the liver. We want to protect your liver while you're taking that medication. Pets are an important conversation to have as well. Pets like cats and dogs are allowed in the home after transplant. If you do have a cat, the litter box is no longer your job. You may not clean the litter box after transplant. That's someone else's responsibility for the rest of your life. Litter boxes can hold really funky organisms that are unique to cats, and though the cat is safe to be around you, you do not want to be around their waste. And so we want to avoid the litter box. Birds and reptiles, however, are very dangerous to someone on immunosuppressant medication and should not be in the home. So if you do have a pet bird or any type of reptile, we will ask that that pet is removed from the home before we proceed with listing you for transplant. If you have different other kinds of pets that do not fit into this category, we can take it on a case-by-case basis. If you are a female, you will be advised to avoid pregnancy. This is because the immunosuppressants that you will be on that are critical to your lung survival are harmful to a growing fetus. Birth control pills can interact with the medications you will be on, and so a second form of contraception will also be needed. When you go to the dentist after transplant, you will need to take an antibiotic 1 hour before you go to the dentist. Once again, this is because of the immunosuppressant medications that you will be on. If your dentist was to nick a gum or you were to have some bleeding during your visit to the dentist, and there was maybe an infection in your mouth or in your gums, it could spread to your bloodstream very easily. So we want to prevent any spreading of that infection. And so we do what we call kind of a prophylactic antibiotic before the dentist. You will not be able to receive live vaccinations such as the MMR vaccine or chicken pox and one type of the shingles vaccination after you are transplanted. If you require any of these vaccinations, we may recommend that you get them before your transplant. Once again, do not share utensils, cups, or toothbrushes. We would advise you to not swim in small standing bodies of water like ponds or small lakes with lots of mold or film or algae because of the infections or the bacteria and mold and fungus that can grow in those standing bodies of water. Public hot tubs are very similar to that because of the heat. They can hold a lot of mold and bacteria and put you at higher risk for infection because of your immunosuppressed state. Now, swimming isn't off limits, right? In rivers and lakes that have good water flow and definitely not in pools. And once you are cleared by your pulmonologist for swimming, if that's something you enjoy, we want you to be able to get back to that. We may recommend you wearing a medical alert necklace or bracelet. In case of an emergency, someone would know that you are a transplant recipient. Because of the medications you will be on after transplant, you will be at a higher risk for burning and also skin cancer. And so it's very important that you definitely do not access or use any tanning beds. And when you're out in the sun, to use SPF or sunscreen with an SPF of at least 30 and sunglasses and hats to protect your skin. You will be on a lot of medications lifelong after transplant. You will be on a combination of 3 immunosuppressant medications and then generally a combination unique to you of antimicrobials. This includes antibiotics to protect you from bacterial infections, antivirals to protect you from a viral infection, and sometimes an antifungal to protect you from a fungal infection. There will be a lot of adjunctive medications that are added as well. What this means is you are placed on these medications because of the side effects from your immunosuppressant medications. And so that list there that you see, you could be on any combination of those medications. Our pharmacists have resources that they will use to teach you about all of your medications, both before and after transplant. You will receive education through a video during your formal lung transplant evaluation class. And we also have resources online, both in the PDF education booklet and by video that you can reference as well for a more detailed explanation of post-transplant medications. Sometimes the medications that you are on after transplant may cause your blood sugar to go up, your blood pressure to go up, maybe because of high cholesterol, or your kidneys may be impacted by your medications as well. Sometimes those side effects may lead you to have to adjust your diet to optimize the levels of sodium and sugar in your bloodstream. Our dietitians will be available to help you navigate an appropriate diet to best protect your health. Most individuals or all of individuals are recommended to be on a low sodium, low fat, and low sugar diet. This is going to be extremely important for you after transplant as well. Sometimes patients need to follow just a well-balanced diet. Other times they require a more specific diet after transplant to protect them from the side effects of their medications. And our dietitian will work with you, if that's the case for you, to find something that you can follow in a diet that works for you.
So to wrap up here, we want to talk about our support group. The support group is run by our social work team. They are in charge of setting up the meetings. They generally meet about once a month, and our social workers can help you to get that information about where they're meeting and things like that. If you have any questions, you can always contact the pre-lung transplant nurses and we can get you in contact with them as well. But they do a whole range of different events throughout the whole state. Actually, they've got different branches in different places, and really all of their events just help to promote organ donation and also specifically help you work through the process of lung transplant evaluation, being placed on the list, and even post-transplant life as well. And again, we just wanted to really reiterate that our main goal of lung transplant really is to improve that quality of your life or the life of the patient with the end-stage lung disease. There's obviously a lot that goes into it. There can be a lot of complications and difficulties throughout the process. There's a lot of follow-up and a lot of visits with us. But really our goal of all of this is to make your quality of life better. Again, lung transplant is not for everyone. If you have any other questions or concerns, please reach out to the pre-lung transplant coordinators. We want to thank you so much for joining us today. And we really encourage you to look at all of those other resources that are available to you, whether on our website through the videos and through the PDF and printed materials, or to look at some of those other resources that we mentioned as well, the OPTN, the SRTR, all of those types of places to really get as much information as you could need or want about lung transplant. And just thank you so much for being with us today.